Okay, great. I'll start. Hi, everyone. My name is Nick. I'm a first year medical student at the University of Illinois College of Medicine at the Chicago campus. Today, I'll be presenting on Chapter 6 of the IR Playbook titled The IR Roadmap Vascular Anatomy Overview. And I want to give a quick shout out to Dr. Tanius for reviewing this presentation. I have no disclosures. Arteries, of course, they move away from the heart. There's a lot of slides here that I've included just for completeness. So anything that the chapter talked about, I decided to put in here. Circle of Willis, VIR doesn't touch too much. It would mostly be neuro-IR that messes with this area, but it's still important to know regardless. So the anterior supply is coming from the internal carotids, which are found here bilaterally. Posterior supply is from the vertebral arteries, which run from the back, and they branch right off of the subclavian arteries, which I'll talk about soon. And then the anterior and posterior supply is connected via the posterior communicating arteries, which are found right here. The next slide goes into a little bit more detail. So this is a 3D reconstruction of an MRA. There's a lot that's going on here, but I'll go through it slowly. Everything's labeled with colors, so you have the internal carotids in pink. They're found bilaterally. These are just two little nubs. Um, then you have the vertebral ones, which I talked about before. They run posteriorly, and they form the basilar artery, which is one singular artery. It's quite large and easy to locate. Then you also have a lot of communicating and cerebral arteries. So you have the anterior communicating arteries, and then you also have the posterior communicating arteries that I just talked about. And then something significant with the anterior communicating arteries is that 30% of ruptured intracranial aneurysms occur with the anterior communicating arteries. And then there's a lot of cerebral or cerebellar arteries. So you have the anterior, middle, and then posterior. And then you also have the SCA, which is a superior. You have the anterior inferior and posterior inferior. I've just included those for completeness because they're labeled on this image, but they're not technically part of the circle villus. And then something important to know for the middle cerebral artery, 80% of large vessel strokes occur here, and then also a remaining 30% of intracranial ruptured aneurysms occur in this area too. So um, that's probably the main significant point in this area. Aortic arch and supraaortic branches. So the aortic arch provides blood supply to the head, neck, upper extremities from its branches, and then the bifurcation of the common carotid. You have the external internal carotid arteries, and then the bifurcation itself contains the carotid sinus, so regulates blood pressure with baroreceptors. Subclavian arteries supply neck and chest, and as I mentioned, the vertebral arteries branch off of the subclavian, and the subclavian ultimately becomes the axillary artery. And then I'll go through the image slowly now. So um, you can imagine the heart right here, ascending aorta, and then very proximal branching off of the ascending aorta. You have the right and left coronary arteries supplying the heart. You're moving up, you have the aortic arch, and then branching immediately off that is the brachiocephalic artery. And it's important to know that you only have one brachiocephalic artery. It's present on the right side of the body. The venous system has two brachiocephalic veins, while the arterial system just has one brachiocephalic artery. The brachiocephalic artery eventually becomes right subclavian and then right common carotid. And then you also have the vertebral artery, like I mentioned, coming off of the subclavian. There's other branches coming off of the subclavian. They're not listed in this picture. So that's like the dorsoscapular, thyrocervical trunk. A lot of those supply some of the shoulder region as well as the back. You're not going to access those too much. Maybe if you're doing like a shoulder artery embolization for adhesive capsulitis, you might be going into those. You might access the thyrocervical trunk if you're doing like a thyroid artery embolization. I think it branches off into the inferior thyroid artery, so that's something that you might use it to access. If I'm not mistaken, I think VIR physicians usually they'll touch the common carotid for stenting, but I don't think they'll go past that. Neuro IR usually handles all of that stuff. Aortic arch after the brachiocephalic gives rise to the left common carotid and then left subclavian. Same idea on both sides. So you have the vertebral arteries, common carotid branching, and then the aortic arch moves downwards, becomes thoracic aorta. And I'll talk about that soon. This is a 3D reconstruction of the CTA. This is just the same the same structures shown. You can see a few more smaller arteries branching off the subclavian. I'm not going to mention those because they're lower yield, and I'm just trying to talk about mainly the high yield stuff in this presentation. Thoracic aorta. So the most proximal structures that branch off of that immediately, you have the right and left bronchial arteries. They run posterior to the trachea, and they provide one of the two blood supplies to the lungs. The other is the pulmonary artery. So the bronchial arteries, they oxygenate the lung parenchyma, while the pulmonary provide deoxygenated blood for gas exchange. And then a procedure that could be done in this area is BAE, or bronchial artery embolization. So if a patient's presenting with hemoptysis, so they're coughing up a bunch of blood, you can embolize the bronchial arteries. This is a coronal reconstruction of a CTA. You have the right and left main bronchus, quite large. The main thing to focus on is that the bronchial arteries are quite small in comparison to the uh, thoracic aorta. Something relevant in this area to think about is the spinal cord arteries. These, you have to watch out for these when you're doing embolizations in this area. So if you're doing a BAE, like I just said, it's important to watch out for these. If you accidentally embolize one of these, it could lead to paralysis. One of the main arteries to think about in this region is the artery of Adamkiewicz. It arises around T9, T12. And this is a question that was actually pimped on a few weeks ago, which was pretty funny, but you really have to be careful about this artery because it supplies a lot of the spinal cord. So if you embolize it, then you'll get paralysis. And then intercostal arteries, this is included just for completeness, but you have the posterior intercostal arteries arising off the descending aorta, and then they anastomose with the anterior intercostal arteries, which come off of the internal thoracic artery, which branches off of the subclavian. So this wasn't in a previous slide, but I thought I'd mention it so you know where it's coming from. Intercostal arteries, they wrap around the rib cage, provide blood for the muscles and skin of the thoracic wall, and they're also a potential cause of a hemothorax. And then this is a sagittal reconstruction of a CTA. This is just highlighting how many intercostal arteries there are. Moving on to the abdominal aorta, there's a lot going on in this image, so I'm going to go through it slowly. Also, if anybody has any questions, please feel free to drop them in the chat. So celiac trunk is a very important structure to know. It has three branches right off of it. So you have the left gastric artery, you have the splenic artery, and then you have the common hepatic artery, and then all of these branch into more structures later on. I think one of the other slides we'll talk about them. So like the splenic gives rise to the short gastrics, and then the right gastroepiploic, or left gastroepiploic. Left gastric gives rise to like the esophageal branch. But continue on here. So common hepatic gives rise to the gastroduodenal, which gives off other branches, which I'll talk about soon. Also gives rise to the right gastric artery, and then continues on to become the proper hepatic artery, and that goes on to the liver. So the hepatic artery, it supplies a third of the blood supply to the liver, and then the other two-thirds come from portal veins. So I'm going to talk about the portal system a little bit later on in this presentation. Right below the celiac trunk, you have the superior mesenteric artery, quite a large structure. It provides blood supply to the small intestine and then the ascending and transverse colon. Running inferior to that, you have a bunch of the lumbar arteries, which are paired bilaterally, and then you also have the right and left renal arteries. Not shown in this image are the suprarenal arteries. They supply the adrenal glands. And then below the SMA, you have the IMA, so the inferior mesenteric artery. This provides blood supply to the descending and sigmoid colon, as well as a portion of the superior rectum. This is an important structure to know for if you're doing a hemorrhoidal artery embolization. Um, it eventually branches off into the superior rectal arteries. And depending on what type of classification of hemorrhoids and where the patient's getting blood supply from for their hemorrhoids, this might be an area where you have to access. And then another cool procedure that's done in the aortic region are EVARs, so endovascular aneurysm repair. These are a bunch of different variations and cousins of the procedure. So you have TVAR, TAMB, and FEVAR. Gastric arteries, so I briefly mentioned this. Orienting ourselves here. So this is the celiac trunk. As I mentioned before, it gives off three branches. So you have the left gastric artery, and that gives off an esophageal branch, and then it continues on. So this is all left gastric artery, so supplying the lesser curvature of the stomach. You have the common hepatic artery giving rise to the gastroduodenal artery, which runs more inferior. And then you have the right gastric artery, which also supplies some of the lesser curvature of the stomach. And then you have the splenic artery, and that gives rise to the short gastric arteries. And then the left gastroepiploic artery, which supplies the greater curvature of the stomach. And then the right gastroepiploic comes off to the gastroduodenal. So there's a lot going on here, and it's confusing because they're all branching from different points. Um, Something important to know in this region is that the GDA, so the gastroduodenal artery, over here, which is one of the branches of the common hepatic. This is a common area for GI bleeding. And then the left gastric artery is also a common area, but I think GDA might be a little bit more common, as that's at least what the literature that I wrote said. Something else to know in this area. So the right gastric artery, since it's branching off of the common hepatic artery, it's often embolized if you're doing a tear TACE, so transarterial chemo or radial embolization. Since common hepatic and since the common hepatic is going to the liver and you're doing an embolization in that area, you could have non-target embolization. So you have to be careful for it to not go into the right gastric because that could lead to gastric ulcers with the beads moving down in this area. So that's something important to know. And then one last thing, which I didn't mention in this area, but that I don't have on the slide, you can have aneurysms in this area. I was recently writing about a case for a gastroepiploic artery aneurysm. They're super difficult to tell. The only way you catch them really is like via imaging, and it's incidental. Patients usually don't have symptoms, but they have a very high rupture rate. I think it's about 50%, and then obviously that goes undetected usually. And then if they do rupture, I think it's around a 70% chance of death due to hemorrhage. So that's also another thing to know about this area. Phrenic arteries, these are included just for completeness. You have the superior and inferior phrenic arteries. You have the inferior that arise just superior to the celiac trunk. So this is the celiac trunk. This is the inferior phrenic arteries. And they run below the diaphragm, and then you have the superior phrenic arteries, not in this image, branch off of the thoracic aorta, and both of them supply the diaphragm. Pulmonary arterial system, there's a lot that's going on in this image. The main thing to know is that you have the main pulmonary artery coming off of the right ventricle, and you have the right and left pulmonary arteries that branch off of the main pulmonary artery. It's a little bit difficult to tell, but something important to know is that the right pulmonary artery, it its origin's a little bit closer to the main pulmonary artery, so it branches off a little bit more proximally in comparison to the left. So the right pulmonary artery is more prone for emboli being lodged in that area. I talked about how arteries, how they arise from the heart, they move away from the heart. Most of the time they provide oxygenated blood, but the one exception is the pulmonary arteries. They carry deoxygenated blood, and the pulmonary veins carry oxygenated blood. And then this is an image of a saddle PE. I like how some of the companies like Inari with their FlowTriever, how they provide the lung diagrams, just so you can tell the size of the clot. And it's so impressive what VAR can do just with a little pinhole through the body. It can improve somebody's quality of life to such a great extent. This is a CT pulmonary angiogram. Um, this image helps show the size comparison between the left and right pulmonary artery. So the right pulmonary artery, as I said, branches off a little bit earlier from the main pulmonary artery, and it's also a lot larger in comparison to the left. So um, it's a more common area for emboli to get stuck in comparison to the left. Upper extremity arteries. So talked about how the subclavian eventually turns into the axillary artery. There's a lot of different branches in this area supplying some of the back and some of the shoulder. Um, like I said, usually accessed only for like shoulder artery embolization. I'm not sure what other procedures you'd access them for. So coming off of the axillary artery, you have the circumflex humeral, um, wrapping around the head of the humerus. You have the deep brachial or the profunda artery, and then axillary continues on, becomes the brachial artery, and then bifurcates into the radial and ulnar, and then the anastomose towards the distal end of the hand. The radial artery is very high yield to know for radial access, so it's one of the more common access points for procedures. It's also important to know that it's very prone to spasming, so often you'd give a nitro cocktail to dilate that artery when getting access. I wanted to include this. I love what Dr. Kunover in Japan is doing. He's revolutionizing the MSK Embo game. So these are this is an embolization of proper palmar digital arteries. So if a patient's coming in with OA for the distal and proximal interphalangeal joints, you could have some of that neovascular blush as shown in this image, and you can get access like you normally would, and then you can embolize all of that, which is super cool. And it's interesting. I wonder what size catheter he's using, but it must be very small. The internal iliac region, for me, this is the most confusing. There's a lot that's going on in this area. So orienting ourselves here, this is the common iliac artery. You have two, they come right off of the abdominal aorta. And then branching off of the common iliacs, you have the external iliac, and then you have the internal iliac. I'll talk about the external iliac a little bit later on, but I'm going to focus on the internal iliac for this. For this slide right now, you have the anterior division, and then you also have the posterior division. A way to remember the posterior division is PILS, so iliolumbar, lateral sacral, and then superior gluteal. Um, this is superior gluteal. Um, iliolumbar is running more superiorly, and then lateral sacral is running inferiorly. I'm honestly not too sure of many procedures going on in this area, but it's still important to know the anatomy. And then just in general, there's a lot of variations in this region. So it's important to know what's common and then also to know what's different. The anterior division's more high yield. I'm going to talk about this very soon, but to differentiate the anterior versus posterior divisions, you'd want to take on an ipsilateral oblique view. It helps differentiate both of these, both the anterior and posterior division. A good way to just think about the arteries in this region, you just think about the stuff or the different organs that live in the pelvis, and then there's an associated artery that lives there. So you have like the uterine artery, so you'd access that for like a uterine artery, fibroid embolization, inferior vesical artery for prostate artery embolization, but PAEs are super complex and there's a lot of variations with those. So uh, it's important to be skilled in the anatomy so you know what's supplying the prostate because you can have variations and the last thing you want is a non-target embolization going to an organ that you don't want to embolize. Something else, you have the internal iliac, also known as the hypogastric. Um, you can do an HAE or hypogastric artery embolization. This is sometimes done to prevent endo leaks after an EVAR. You wouldn't embolize this whole artery, but you might selectively embolize it. So previously talked about an EVAR, but if you have an aneurysm and you put in a stent, you can still have some blood flow back into the aneurysm, which causes it to be more prone to rupturing, which is obviously not good. So you can go back and embolize some of the areas that are providing blood flow back into the aneurysm sac. So you have arteries like the obturator, superior vesicle, inferior vesicle, uterine, middle rectal. So this is uh, another area that's important to know for hemorrhoidal artery embolization. So there's a lot of different variations on individuals' hemorrhoids, but you can get blood supply from both the middle rectal and then the superior rectal. So if you're doing an HAE, it can sometimes be a long procedure because you have to get access bilaterally for middle rectals and then also superior rectals off the IMA if they have blood supply from both regions. And then internal pudendal and then inferior gluteal. Uh, the next slide has a little bit more about this, so I'll talk about that soon. But something to talk about on rotations or something important to know. So you'd want to take on a contralateral oblique view with the C-arm to differentiate the internal versus external iliacs. So let's say we're accessing the right side of the patient's body. So you'd want to move the C-arm towards the left side of the body if you're having trouble getting access to either the or mainly getting access for the internal. But once you get access into the internal and you want to differentiate posterior versus anterior divisions, you'd want to switch to an ipsilateral oblique view. So you'd move the C-arm back to the right side of the body. This is a CTA of a pelvis in a male. Um, some of these arteries have certain distinct looks. So like the obturator, it's often known for looking like an upside down Y. The pudendal looks like an L, so like a hockey stick. And then the superior gluteal, which comes off of the posterior division, uh, it's known for being the largest in that area. I'm going to move on to the arteries of the lower extremities. So common femoral artery, very common access point. You'd want to access it by the mid aspect of the femoral head. That's important because when you're closing, you want to make sure you're putting pressure on it, and you want to put pressure on it against a bone. Because if there's nothing in that area, it's going to be harder for it to close. So as I mentioned, abdominal aorta, you have the common iliacs, and then off of the common iliacs, you have the internal, external iliac arteries. Um, you have some arteries supplying some of the hip joint. You'd only access those if you're doing like a hip embolization. Um, the common femoral gives rise to the deep femoral or the profunda, and then but it continues into the superficial femoral. Eventually becomes the popliteal in the popliteal region. Um, not listed here or not on this image, but you have the genicular artery. So if you're doing a genicular artery embolization, you'd be in this region to do that. And then the popliteal, it divides into the tibioperoneal trunk. So you have the fibular artery, posterior tibial artery, which I'll talk about soon, and anterior tib. Previously talked about the internal iliac, so you can access it for all of these, which I mentioned. Something important to know is that you can get pedal access for a lot of different procedures. So you could get pedal access for like a post via the posterior tibial artery or dorsalis pedis. So this is dorsalis pedis, posterior tibials, posterior and also a little bit medial. So if you're doing like peripheral artery disease cases or chronic limb ischemia cases, you'd want to get pedal access if you have a lot of plaque in the fem-pop region and you're not able to access it more superiorly. Plantar fasciitis embolization. This is my favorite procedure to watch. You'd want to, you can get access via the posterior tib or you can get femoral access. You have a little bit more torqueability with the wire if you get femoral access. Posterior tib gives rise to the medial and lateral plantar arteries. Um, and then you have a lot of that hypervascular blush. Um, comes off in different regions, but in this picture is coming off of the medial plantar. And just like other MSK embolizations, you'd use a temporary embolic. So you'd use something like Lopidol or imipenem, cilastatin to do that. And then I love the before and after angios. They look so clean, but this is the power of VIR. Now I'm going to talk about the veins. So they return blood to the heart. These are the veins of the chest. So I talked about how you have one brachiocephalic artery on the arterial end, but you have two brachiocephalic veins. You have the superior vena cava supplying deoxygenated blood to the heart. It's important to know that all of this is flowing back down this way. You have the azygous system, but I'm not going to mention that. So two brachiocephalic veins, you have the internal jugulars, and then you also have the external jugulars. And then this is the subclavian, and that eventually becomes the axillary, as shown on this side of the image. You have the cephalic brachial vein. I'm going to talk about that soon. Some important things to know in this region. So you can be putting in IVC filters. So if a patient has DVTs with contraindications for anticoagulation, you can give IVC filters prophylactically as well. That happens in this area. As VC syndrome, so if there's pressure against the superior vena cava, typically tumors like superior sulcus or Pancoast tumors, you can get a lot of swelling and edema. So VIR is often called for stenting or angioplasty in that case. And then super bread and butter central venous catheter placement. You'd want to access the IJ more often than the subclavian. And then there's two types. So you have tunneled and non-tunneled CVCs. You've tunneled, which are more long-term. So you insert the hub under the skin, and then you use the CVC to provide different medications to the patient. And then you also have non-tunneled CVCs. So the hub sits on top of the skin, and it's more short-term. This is a MRV of the abdomen and pelvis. Um, Talk about the portal system soon, but a good way I like to remember that the hepatic vein is superior is that the first letter of hepatic is H. H is the first letter in high, like high above. So hepatic vein is above the liver, and then you have the portal vein, which is below it. I'll talk about that soon. So portal venous system, I'll talk about the procedures first, and then I'll talk about all the different veins that live in this area. So TIPS, everybody's favorite transjugular intrahepatic portosystemic shunt, indicated for portal hypertension. So you'd want to have a stent that's connecting the portal vein to the hepatic vein. So I just talked about how the hepatic vein is high, connects to the portal vein, relieves some of that pressure. You can do a DIPS, so direct intrahepatic portal caval shunt. So if there's an obstruction in the portal vein, or sorry, in the hepatic vein, you can bypass it and you can just create a direct shunt through the IVC into the portal vein. I have an application image in a later slide showing that. You can also do like a portal vein embolization. So you'd embolize um, portal vein branches to a tumor-bearing lobe to allow for contralateral lobe hypertrophy. And then you can also do something like a BRTO or CRTO, Barto-Carto, so balloon-occluded or coil-occluded retrograde transvenous obliteration. And then these are just used to treat gastric varices if a patient has portal hypertension. All right, so talking about the veins in this area. So all these veins are collecting blood from the different organs that live in this area. They're directing it to the portal vein. It's being filtered by the liver, and then the hepatic vein is taking that liver up, and the hepatic vein connects to the IVC. So you have the superior, inferior mesenteric veins, just like you have the superior and inferior mesenteric arteries. Right gastric artery. You also have the splenic, left gastric. Yeah, I think that's all that I have to say for this slide. This is a CT abdomen and pelvis of the portal venous phase. Um, so you have the left and right portal veins. This is the main portal vein. It's collecting blood, so collecting blood from the splenic vein. You also have the renal veins, and the renal veins branch off of the IVC. Sometimes, like on the previous slide, you might have to get like transhepatic, transvenous access to get into the portal system. But if a patient has severe portal hypertension, then they can get a gastrorenal shunt and other shunts that form. So you can get systemic access like you normally would via like the femoral vein or something. And that connects to the renal vein, or the renal vein connects to some of the portal system if they have severe portal hypertension. But if they don't, you might have to get transhepatic, transvenous vein for some of the procedures that I previously talked about. Like I said, tips and dips, transhepatic, intrahepatic portal systemic shunt, stent connecting hepatic and portal vein, and then if there's an occlusion in the hepatic vein, then you can stick the IVC directly into the portal vein. Now moving on to the veins of the upper extremity. So you have the subclavian vein branches to the axillary, and then axillary branches off into the uh, basilic, brachial, and then cephalic, median cubital, and then you also have the radial ulnar. I don't think this is too high yield to know I don't think there's too much that goes on in this area. But a good way just to differentiate the basilic versus cephalic, because I mix those up all the time. Basilic sounds like base rhymes with face. Face is more medial. So you know basilic's on the medial side while cephalic's on the lateral side. Something, some clinical correlate in this region's Paget-Schroeder syndrome. So if a patient comes in and they had strenuous overhead movements, that could lead to the subclavian artery being squeezed between the clavicle and the first rib. This is a very good environment for a thrombus to form. So VIR would come in and they would do catheter-directed thrombolysis. This is a question for all of you, but would you stent in this area? It's okay if nobody knows. Okay, I don't see anything in the chat. I know I didn't give you guys much time, but you wouldn't want to stent because the stent would get crushed. So that's why you'd only do thrombolysis if they come in with Paget-Schroeder syndrome. Veins of the lower extremity, um, very similar to the arterial side of things. You have the common iliac, branches off to internal, external, deep profunda. You have the great saphenous vein, often used as grass for different procedures, popliteal, and then you have fibular vein, posterior tib, anterior tib. Um, you want to know some of this anatomy if you're doing PAD work or CLI work. So the most common site for acute DVTs is popliteal and common femoral, um, also called the FemPop, which I really like that name. Something important to know just because we're on the slide. So if you're getting like femoral access, you need to know that veins are compressible in ultrasound. So if you're getting ultrasound guided, you can squish the veins when you give pressure, but the arteries don't squeeze. So if you're either getting access via the femoral artery or femoral vein, that's how you would differentiate them. Something else in this area, venous insufficiency. So you do something like sclerotherapy, which would help seal the problematic veins, and it helps. It acts like a glue. I included lymphatics, just one slide. So this is some of the more high yield stuff. Right side of the body, or just right upper extremity, it all of the lymph flows into the right lymphatic duct, which enters via the right subclavian internal jugular vein junction, so right venous angle, and then the left side of the body as well as the lower region of the body drains into the cisterna chyli, which drains into the thoracic duct. Thoracic duct, the largest lymphatic vessel in the body, and then cisterna chyli and thoracic duct they give the lymph back in through the left venous angle, which is the junction of the left subclavian and internal jugular. Two high yield lymphatic procedures, so thoracic duct embolization. So if a patient has a chylothorax, you'd want to embolize it. And then if you're doing lymph angiography, you'd want to just get access via the lymph nodes. And then you would identify a chylothorax with that. All right, that's it for my presentation, but I have five practice questions to quiz you all on. So this is the circle of Willis. Um, this is just an identification question. What artery is this? You can unmute yourself. You can type it in the chat. It's just this thing.
Is it the basilar artery?
Yes, it is. It is. Okay, sweet. And a few people typed that out. Awesome. Yeah, so this is the basilar artery. Like I said, the mainly high yield stuff to know, you have the internal carotids, vertebral, basilar, and then you can have aneurysms and strokes forming in the MCA, so that's also important to know. Okay, this is also another identification question. Um, we're in the arterial system, so I know there's a lot of numbers here, but can feel free to unmute or type it in the chat. So one, two, three, and then four, five, six. Okay, that's okay. There's a lot to name anyway. All right, so this is the aortic arch, right? This is brachiocephalic artery. This is um, common carotid. This is subclavian, right? Left subclavian artery becomes axillary artery, and then it continues on to become the left brachial, and then you have the radial artery, which is more lateral, and then the ulnar artery, which is more medial. Um, then I this wasn't on the previous slides, but you also have like the humeral circumflex artery and then long thoracic artery, so supplying parts of the back. All right, this is both identification plus application. And this is a little bit of a tricky question, but what artery is the most common source for GI bleeds? So I mentioned two arteries during this presentation. One of them was the left gastric artery. I'm telling you right now that the answer is not the left gastric artery. So it's the other artery that I mentioned, but I know there's a lot going on in this region. Yes.
The
Ge-
gastroduodenal? Oh,
yes. What letter is it?
is that E?
Yes, it's
Yeah.
E. Awesome. Thank you, Zach. Yeah, it's E. So yeah, there's a lot going on in this region, but this region is very, very important to know. So I'll go through all of it once again. So you have the celiac trunk. You have three branches right off of it, right? You have the left gastric artery, you have the splenic artery, and then you have the common hepatic artery. And the common hepatic artery goes to the liver, and then it gives off some more branches. So GDA is one of them. Right gastric is another one, but right gastric I don't think is shown here. Uh, the common hepatic becomes proper hepatic, and then you have the left and right hepatic arteries that branch right off of it. Also in this image, you have the SMA. You can tell how much larger the superior mesenteric artery is in comparison to the IMA. And then the superior mesenteric, both artery and vein, they are a little bit more on the right side, and then the inferior mesenteric artery and vein are a little bit more on the left side. So that's also something important to know. All right. What artery is this? All right. Yes, Brian, left popliteal. Exactly. Okay. Left popliteal. I mean, this region's a little bit of a gray area, so I guess that's why it's also called fempop, because the distinctions might not be as clear as something like the conversion of like the external to femoral via the inguinal ligament. So, yeah, this is the left popliteal artery, fempop region. I'll go through some of the stuff again. So, two common iliacs. You have the internal iliac, you have the anterior and posterior division. External iliac continues on, becomes common femoral once it crosses the inguinal ligament. You have the deep femoral, also known as the profunda, that branches off of it. The SFA continues down popliteal. Then you have the tibial-peroneal trunk. You have the posterior anterior tib, and then you also have the peroneal artery. So the peroneal as well as the posterior tib come off of the tibial-peroneal trunk, while the anterior tib just comes right off of the popliteal artery. All right, last question. What is this structure? I'm not going to tell you if it's an artery or a vein. You also have to figure that out.
Left subclavian vein.
Yes, left subclavian vein. Yeah. So I tried to trick you guys a little bit. This is the SVC because it gives off two brachiocephalic veins, right? This is the aortic arch. It has the brachiocephalic artery, right? It's not present on the left side. You just have the common carotid and then you have the subclavian that comes right off of it. So yes, left subclavian vein. This is everything else in the image. SVC is a little bit more lateral to the aortic arch. I guess you could say aortic arch is pretty midline. Okay. Some final tips for success. So just knowing if you're in an artery or a vein, just knowing where you get access, very important. Then you know what part of the body you're in, so then you know what system you have to focus on. Knowing what is the main artery or vein or the main structure that it's coming from, and then where is it going to? So maybe you're in the thoracic aorta, and then you're going to like the left kidney, right? So left renal artery. Something seems off, maybe it's a variation. There are so many variations. This is like this is just textbook perfect. I don't think there's ever a patient that has this perfect of anatomy, but it's important to know what's common, and it's also important to know what's a variation, um, and then understanding your view. So AP, oblique, and just knowing your laterality. It's quite simple, but all of that goes a long way. And that's it for my presentation. So thank you all for coming. Um, This is just a meme that I wanted to put in. I wish everything was as organized as this is, but it's not the case. And then this is a link tree to our organization if you're curious to learning more about us. But happy to answer any questions to the best of my ability.
Nick, thanks for this awesome comprehensive presentation. You did great.
Thank you,
I,
thank you.
I have two questions, if that's okay.
I'm gonna try my best.
So, arteries and vessels, they have different structural differences. I know that arteries are tend to be thicker because they have more smooth muscle and elastic fibers, while veins have less of that. Does that dictate the different procedures that VI physicians do and where they access?
I think the most important thing for access is just knowing your endpoint. So let's say I don't know. Like I talked about a lot of the MSK embos, like all of that's through the arteries. So you would never get like venous access for something like that, right? You'd need to get arterial access. I guess one of the variations in that case that's a little bit confusing is like if you're doing a PE case, it's called the pulmonary artery, right? But you want to get venous access because how do you get to the pulmonary arterial system? You have to go through the SVC, which is venous. Um, so all of it comes down to like what's the end point of the procedure? Because you wouldn't want to be doing something on the venous end and get arterial access because I don't know in what point you'd cross over. Um, unless yeah, I don't know where you'd cross over. but I'm sure there's some exceptions to that rule. Like if you're doing PAD and CLI work, I think sometimes you do have to cross over and make new connections. I forgot what some of the procedures are called, but I know there's you change some of the flow of the blood in that area. Yeah.
Awesome. And then my second question is, what's your favorite blood vessel?
Favorite blood vessel. Oh, I don't I don't know. AV fistulas. Yes, thank you, Zach. Um, you do that for like dialysis, I'm pretty sure. And I'm sure there's other things you'd want to do that for. Favorite blood vessel. I don't know. I mean, I love, like I said, I love watching plantar fasciitis embolization. So like I guess posterior tibial artery is my favorite, but
Awesome.
that's a good question.
Great presentation, Nick. Just for all the people that are watching and then those who might see the recording, any practical tips on how to study anatomy daily? That's one of the things that Dr. V really harps upon to become a really good IR and physician in general is, no matter how many times you've gone through anatomy courses, you always seem to forget things. So any tips that you found useful while you were doing this presentation or that you use in your daily practice?
Yeah, that's a very insightful question. I'll start off with this. In undergrad, I was very lucky to have access to a cadaver lab. So I started studying anatomy quite early on, and I used the Blue Link Atlas Anki deck, if anyone has heard of that. So I've been using that for a while, and that got me really familiar with some of the vasculature. I think like by far the most important thing is just getting in the suite and getting reps in because you can see all of these arteries in a textbook. You can nail it down, but as soon as you get in the suite and you see an angio, like it is so difficult to tell some of the things apart. Like I mentioned, there's so many different variations too, and I don't know any variation yet. But the variations are really important to know, especially for some of the more niche procedures, because you wouldn't want to embolize something that you're not trying to. Um, so I think, I mean, just like anything else in this world, I think just getting the reps in is super important. Yeah, happy to hear how any of you study anatomy. I'm a lot younger than some of you in this call. Okay, any other questions? Thank you all for coming. I really appreciate it.